Welcome to the program on causes of cognitive dysfunction in depression. In this presentation, I will talk about the different contributing factors to cognitive dysfunction in depression, ranging from psychological, social to biological factors. My name is Bernhard Baune. I am Professor and Chair of Psychiatry, Head Discipline of Psychiatry, University of Adelaide, Australia. These are my disclosures indicating funding sources from a variety. So why do we focus on cognitive symptoms in depression? We found that cognitive symptoms do persist during periods of remission and subsequent depressive episodes, as shown here in this 3-year study. And importantly, they not only persist, but if you compare them to other core symptoms such as depressed mood and diminished interest, actually cognitive symptoms seem to be more prevalent and more prevalent in terms of the time spent with these symptoms by patients over time. So therefore they seem to have an important relevance to patients. These cognitive symptoms, often also referred to as cold cognition or non-emotional cognition, they are represented by certain domains of cognition, such as learning and memory, language, cognitive function, relates also to executive function, problem solving, and attention. And these domains, they consist of a variety of individual cognitive tests and functions, such as working memory, processing speed, and other things as we go into the details of each of those domains. But what's been found is that the variety of these domains are affected in a broad spectrum profile in patients with depression. So therefore, it's not just an individual like memory or another domain, it's really the broad spectrum of these domains being affected in patients with depression. And the degree is clinically quite significant, as we found in a number of different studies that up to 40% of patients exhibit really significant cognitive deficits. This is not only applying to patients in the older age group, but more importantly in the typical depressed patients of the adult age, but also in young individuals and even individuals with the first episode of depression show cognitive dysfunction as a prominent symptom. These symptoms are obviously marker of current depression, so they do occur in an acute episode, but they also seem to last into remission. So when patients' depression is regarded as being remitted based on depression rating scales such as HAM-D or MADRS, or also clinically, many of them do actually have continued cognitive symptoms which may impact on their overall function. So therefore, the causes and contributing factors that are typical and have been described for causative factors for depression, such as psychological factors, social factors, biological factors, and also brain structure, brain function, brain circuitry factors, these are all also factors which may contribute specifically to cognitive dysfunction in depression. And this is what we will be talking about in the next 25 to 30 minutes, about the range of different factors contributing to cognitive dysfunction, either directly, such as some biological mechanisms, or more indirectly, such as childhood maltreatment, being maybe a long-term trigger, not only for the onset of depression, but for functional and structural brain changes relevant for cognitive dysfunction. So we'll talk about these things in some more detail as we go along. Now, when we talk about cognitive components, then we have to keep in mind that these cognitive components, these cognitive functions, are not occurring in isolation. It's very important for this program to keep in mind, because they interact very closely with the emotions, with emotion processing, but also with behavior and how behavior is sort of determined by what we think, what we feel, and vice versa, it is also determined what we think by what we feel and how we behave. So it's a close interrelationship, and only this triangle as shown here between the three components taken together then impact also on psychosocial function in depression. Now, an important part of psychosocial life in these days is for patients with depression to be at work and to continue to be at work, ideally even while being depressed or being treated for depression. But many patients receive and require inpatient hospital treatment or more intensive treatment even as outpatients. And what is important then to look at the reintegration rate of those patients going back to work, and what we've come to learn through a variety of different studies is that when patients go back to work after treatment, then a certain proportion of those patients actually does not reintegrate well at work, which is about 1/3 of those patients. And it has been speculated that the lack of reintegration relates to a lack of recovery of function, and an important aspect of those functional recovery components is then cognitive function being an important player here. And that's been also suggested in this triangle which you see here between cognitive function, daily function, cognitive function being an important mediator of that function, that this cognitive function and dysfunction is worthwhile looking at more closely. And what's been done in this study that in a first sort of type of analysis, it has been shown that the symptom reduction in depression relates to an improved work productivity. But then what we also see is in those individuals in the study whose work productivity remained impaired, despite depressive symptom reduction, that this is a group of patients that is potentially suffering from other components of depression, such as cognitive dysfunction, that are not fully remitted and therefore impact on work productivity over time. Now, among these psychological factors in this triangle of thinking or thoughts, emotions, behaviors, are certain psychological factors that impact on the way we think and also on cognitive tasks if they are formally tested, such as performance anxiety, then the negative bias, which is quite specific also to depression, the aspect of having low expectations of oneself's performance, may be related also to low self-esteem, lack of confidence to perform well, to function in the workplace, for example, or in other day-to-day situations. But also then we've observed, and we come to talk about that in a moment, about oversensitivity to negative feedback leading to worse performance down the track. And often patients do suffer from ruminations, especially in the acute phase, but also in remitted stages where ruminations are still present in some cases. And these ruminations preoccupy the patient's way of thinking and feeling, and sometimes also behaving, which then limits their ability to function cognitively at a higher level. And that's also been shown in some tasks on emotional memory, where patients, compared to healthy controls, do not recall as many items of positive content as one would expect if one was healthy in this study. And similarly, another study showed on comparing objective results from a delayed matching to sample test, which is a task on memory testing, as well as on the one-touch Stockings of Cambridge, which is an executive function test in depression and Parkinson's disease patients, schizophrenia patients, compared to controls, that if patients, or these groups would perform the test repeatedly, that they would show improvement in their performance, which is shown on the left-hand side of this slide. However, if then in the study protocol, in the experimental protocol, an element is given to provide feedback on the participant's performance, and in terms of negative feedback specifically, for example, saying that the performance on the previous task wasn't done that well, then we see specifically for depressed patients that they perform much worse in the subsequent task following that negative feedback as compared to control patients control participants which are not affected by this negative feedback. And also Parkinson's disease patients and schizophrenia patients are much less affected by negative feedback than depressed patients. So this seems to be quite specific to depressed patients, that oversensitivity to negative feedback really strongly impacts on their on the performance on cold cognitive tasks. But also we've come to learn that other clinical variables such as severity, number of episodes, duration of illness may impact on cognitive performance, maybe directly or through then changing brain structures such as reducing hippocampal volume, and thereby indirectly impacting on the ability of learning and memory. And this study here shows that a close relationship between the number of untreated days of depression, which with increase of those days, there's a reduction in total hippocampal volume in female outpatients with recurrent depression being in remission. This really clearly indicates that the duration of untreated illness is impacting negatively on hippocampal volume. And similarly, the number of previous depressive episodes in a large study of more than 8,000 outpatients with MDD shows that with from 3 and 4 episodes and above, particularly that the number of corrected recall items or recall responses is reduced following that clinical variable of disease duration and the number of depressive episodes over time. Now, a more distal potential factor contributing to depression onset, but also to cognitive dysfunction, is childhood maltreatment. Childhood maltreatment, which often occurs, around in the first sort of few years or first decade, 12, 13 years of life, has been found to have a profound impact really on the likelihood of developing mental illness in adulthood, but also trauma experienced later on in adolescence or in adulthood has also impact on comorbidity, not just on depression, but comorbidity of a variety of psychiatric problems, including also drug and alcohol problems, but also, more importantly, on the rate of committing suicide. And we found in a number of studies that around 40% of adult psychiatric illnesses have an early stress component as a contributing factor or maybe a causative factor, and around more than 20% of depression and mood disorders are really attributed directly to early life stress. So early life stress has at least a clinical important role to play in the onset of depression and contribution to comorbidities, but also it may affect then also biologically some of the stress response aspects and increases inflammation maybe early on and modifies the immune function from quite early onwards, leading to an increased risk of depression later on. And that early life experiences and particularly maltreatment can have lasting effects on brain function and brain structure has been shown numerous times, and this is one of the very first studies which you can see in this slide, where childhood maltreatment has been measured retrospectively, and brain function and brain structure has been measured in adulthood. And what's been found is that an increased scoring on the childhood maltreatment questionnaire, the CTQ score, was associated positively with right amygdala responsiveness to negative facial expressions, which you can see on the left-hand side, and on the right-hand side you can observe that increased CTQ scores were associated with lower hippocampal gray matter volume, again on the right-hand side of the brain. Now, this has come to lead us to an understanding that these early life stress, but also other components like personality traits and genetic factors contribute to the, as life stresses, if you like, or as vulnerability factors, contribute then to the biological components of underlying major depressive disorder. But also within that, we've come to understand that, for example, the inflammatory response or inflammatory tonus is modified through these ELS, personality traits and genetic factors, and thereby leading not only to the major depressive disorder as such, but also to specifically cognitive dysfunction in these populations, and also decreased neurotrophic factors has been described elsewhere before. Now, the structural and functional brain changes, which we can observe in depression, may all have impact to some degree on cognitive function in depression as well. And this is a summary here of these functional and morphological brain changes in depression, which most of you will be very familiar with, mostly volume reductions in a variety of brain areas and activity increase, for example, in the amygdala we talked about already, but also somewhere like in the ventral striatum, there can be a decrease in functional activity as well. Now, the relevance for psychological function and cognitive function specifically has been shown here. So these brain areas which you saw before, they are not working in isolation, they're working in a network, which is depicted here in this slide with the various brain areas such as amygdala, hippocampus, ventral pallidum, ventral striatum, and so forth, the prefrontal cortex. They themselves have important functions, but in the interrelationship, for example, between the amygdala and the orbital-medial prefrontal cortex, there is a close connectivity there and regulation occurring, which is highly relevant for emotion control, emotion processing, but also how emotions may influence actually then executive function or other sort of memory tasks, which is shown here. For example, that there is a sort of we can describe a top-down process of cognitive control from the prefrontal cortex leading down to the anterior cingulate cortex, the amygdala, but also then have certain areas and circuits which are predominantly responsible for processing of information, whereas others are predominantly responsible for the emotion processing as such, and then their interrelationship in this top-down called cognition model. Now, a number of biological mechanisms have also been suggested to not only influence depression, but also then cognitive dysfunction. And depression research has come up with a variety and a good understanding now of underlying molecular mechanisms, of cellular effects of these mechanisms, and also how they lead then to overall morphological and tissue changes in depression. And I won't go through all the details which you can see on this slide here, depicted to illustrate the effects of acute stress within a few hours, days and weeks, and then persistent stress over several weeks and months and even years, how they relate then to these molecular, cellular, and also morphological changes, leading up to the development of major depressive disorder, and maybe also to the risk of recurrent major depressive disorder. All of these different aspects of neuroprocessing relate then obviously at the network level to certain neuroactivation patterns, to task-dependent activation as well. Now, one of the examples is in terms of mechanisms affected in depression and heavily discussed in recent years is the involvement of the immune system and inflammation in particular, not just peripherally in the bloodstream, but also within the brain. And here is a study which suggests from post-mortem analysis of depressed individuals versus healthy controls that the subgenual anterior cingulate cortex microglia area is activated in this particular study. Now, the microglia activation clearly relates to the quinolinic and quinolinic acid pathways, which are intertwined with the serotonin and pathway, the degradation from tryptophan to serotonin, and the influence actually of inflammatory markers such as interleukins on that mechanisms, leading to an increased level of quinolinic acid and mainly in microglia. So this microglia activation, or the activity on neuroinflammatory processes within the microglia, has been also studied in PET studies. So try to make visible these underlying inflammatory processes in the brain, which cannot be accessed directly but indirectly through PET and TSPO marker, which indicates not only that there is an elevated TSPO level as a marker of neuroinflammation in patients with major depressive episodes compared to healthy controls, but also that certain brain areas such as the prefrontal cortex, the anterior cingulate cortex, and the insula have shown a specific increase in this particular neuroinflammation marker. Now, neuroinflammation it has been discussed as a pathological mechanism for depression, for cognitive dysfunction, but also we have to be aware that, which you can see on the right-hand side here, that immune markers or cytokines, interleukins, sometimes also or chemokines are involved in the physiological function of mechanisms relevant for learning and memory, such as interleukin-1 beta, IL-6, TNF-alpha, which are closely related to synaptic scaling, to other mechanisms subserving then LTP in the hippocampus, so long-term potentiation, and also long-term depression, which are important molecular mechanisms of memory and learning. And if there is microglia activation through peripheral inflammation, for example, and increased inflammatory markers coming from the microglia, then the molecular processes subserving then LTP are impaired, and TNF plays a major role in this, as well as interleukin-1 beta as key markers of inflammation, and thereby disturbing also the mechanisms for learning and memory. Now, another marker in TNF-alpha, so tumor necrosis factor alpha, has been shown to be, as I just explained, to be relevant for physiological function in moderate expression. And this moderate expression is important for neuroprotection, for normal hippocampal development, synaptic scaling, and so forth. However, if there is a lack of this marker, so a lack of TNF completely in the brain, then we see cognitive decline, cognitive dysfunction through improper hippocampal development and other, for example, cell death in NGF-dependent neurons. On the other hand, if we observe then an overexpression of this marker brain specifically, for example, then we also observe cognitive decline, for example, through mechanisms such as increased ICAM production and increased overall inflammation. Other studies, which suggest more clinical studies here, show that differential gene expression for patients with and without cognitive dysfunction in remitted depression show an involvement of the ribosomal protein S26, but but also the B lymphocyte proliferation being relevant for cognitive dysfunction in remitted depression. This body or this type of research has suggested that a number of different immune factors, from cytokines, chemokines, immune cells, T cells, and glia, microglia, astrocytes we've talked about briefly, have a diverse impact on neuroplastic processes in the brain, on neural stem cells function, on neuroanatomy and neurocircuitry, neurotrophin and synaptic plasticity, all of which are subserving then emotion processing and also cognitive function. Thereby, the immune system really in its variety of cell types via the impact on neuroplastic processes impacts directly as a causative factor on processes of cognitive function. And in clinical terms, we've come to understand that in a variety of patient groups, inflammation may be increased during an acute episode, which you can see here, an upregulation of a number of different immune markers, and thereby leading to symptoms of depression, including also cognitive dysfunction, which then may be recovered in the post-acute phase, going hand in hand with a reduction in these markers. On the other hand, if there is no recovery and no remission of symptoms, we also find an increased and continued increased level of inflammatory markers and immune cell dysregulation, which may lead actually to an ongoing impaired cognitive status in these patients and those which we've seen previously in the study on cognitive dysfunction in remitted patients. Now, these inflammatory changes also relate often to metabolic changes, and type 1 diabetes patients are an example where we have both a metabolic change and inflammatory change often occurring. And these patients on their own, compared to healthy controls, show altered brain connectivity patterns, which are associated with lower executive function, but also with a higher default mode network connectivity. And we find that patients with diabetes mellitus type 1 and type 2 have a strong comorbidity with depression, and this comorbidity particularly relates also to increased rates of cognitive decline during aging, but also additional vascular risk factors as pretty much well known: low blood pressure, sometimes also high blood pressure. There's controversy around that. Low physical activity, metabolic syndrome, smoking may also actually worsen than this comorbid condition on diabetes mellitus and depression in the development of cognitive dysfunction during aging processes in community dwellings. And this leads me to sort of summarize and bring together the integration of clinical, psychological, social, and biological dimensions in depression, as we've discussed throughout this program, leading to, as vulnerability factors and lifetime stressor factors, having direct and indirect effects on the development of biological pathways leading up to depression in adulthood, but also then having an impact on inflammatory and immune markers, which are more directly related to impaired cognitive dysfunction in depression. So just to summarize and conclude, so we've seen a range of psychological, social, workplace-related factors, biological factors in depression that also may contribute to cognitive dysfunction in depression. And within that, the research suggests that functional and structural brain changes in depression broadly impact on cognitive processes of emotional information, non-emotional information, and also of social information. And inflammation and immune dysfunction may be a factor which play a role in the development of depression in the long term, but also in the short term as an acute marker of depression. They have a direct impact on cognitive dysfunction within depression. So it's important to understand the etiology of cognitive dysfunction in depression, that there is an overlap between depression etiology, pathophysiology, and specific aspects onto cognitive dysfunction as well. But it's interesting to look at the complexity because this may actually open up the ability to identify new treatment targets based on some of these mechanisms for depression and cognitive dysfunction. So I'd like to thank you for your attention for this program, and I hope you find it stimulating and follow this up with some further reading. Thank you very much.